Good morning, everybody. For those of you that don't know me, I'm Ellie. I'm the EMIM PGY3s, and today we're going to discuss the eFAST overview, really focusing on the special populations and the evidence and recommendations behind the exam. Special thanks to Drs. Allen, Hannison, both Dr. Lees, and the entire Sino lecture team series. We'll start with a brief overview, really discussing the techniques, image interpretations, and just a disclaimer. The beginning of this lecture is really going to focus a lot on the basics. Most of you will already know it, but being that we have some new interns, it'll be a little bit beneficial to review all those aspects. Give me 1 second. I just have to move out the. So just an overview, we're going to do a little review of the eFAST exam. We're going to discuss data with the special populations, specifically regarding pediatrics, the pregnant population, and young females. We'll go over some tips and tricks for the exam, and we'll discuss some recommendations from the professional societies regarding the eFAST exam. We'll start with a little history. For most of you, I didn't know this, but this is Saisekai Kanagawagan Hospital in Japan, where ultrasound was actually used as an adjunct tool in the assessment of abdominal trauma since 1982. So this is not actually a new thing. The FAST term was coined in 1996. It was actually initially called the Focused Abdominal Sonography for Trauma, and then it was changed in 1997 to the Focused Assessment Sonography for Trauma, because it included more than just the abdomen. It's performed in the secondary survey of the ATLS exam, and it's now the standard of care in most trauma resuscitation algorithms. The sensitivity and specificity of the exam are 74% and 98% respectively for a positive exam detecting intra-abdominal injury. These numbers actually vary depending on the studies that you're reading. Most of the studies report varying sensitivities of 60 to 100%, but some of them actually are as low as 42%. There was a meta-analysis published in the Canadian Journal of Emergency Medicine in July of 2019 that reviewed 75 studies, which included just under 25,500 patients. The studies were published between 1989 and 2017. And what they found is that the pooled sensitivities and specificities for detecting a pneumothorax was 69% sensitive and 99% specificity. For detecting a pericardial effusion, it was 91% sensitive, 94% specific, and intra-abdominal free fluid, 74% sensitive, 98% specificity. When they did a subgroup analysis for detection of intra-abdominal free fluid in hypotensive patients, the sensitivity was 74%, specificity was 95%. And it dropped significantly in pediatrics, which we'll discuss later. With the FAST exam, you can reliably detect as little as 200 to 250 cc's of intra-abdominal free fluid. This is the standard trauma algorithm that most places use, and it really shows you the utility of where the FAST helps. So it helps in clinical decision-making when you're discussing determining the need for a CT abdomen pelvis in a hemodynamically stable patient with blunt abdominal trauma. And also with a positive FAST in an unstable patient, you can avoid doing the DPL and take them right to the OR. These are the ultrasound probes, various ultrasound probes using for different exams. For the FAST exam, we use the curvilinear probe. It doesn't have the best resolution of all the probes. However, it does have a deeper image with decent resolution, so that's why we use it for the FAST exam. These are the typical views for the FAST exam. 6 views, the right upper quad, left upper quad, the suprapubic, subxiphoid, and the thoracic views. And you would perform the exam in that order. This is the views of the right upper quad. You're looking to evaluate fluid in Morrison's pouch, which is the most dependent area. That's between the liver and the kidney. You're also looking to make sure that you get the diaphragm in view because you want to see above the diaphragm to evaluate for any fluid in the thoracic cavity. And just avoid the pitfall. Make sure that you identify the liver tip because that's where fluid starts to accumulate as well in the right upper quad. This is the view of the left upper quad, similar to the right upper quad. You want to make sure you have the diaphragm in view. The fluid typically accumulates between the spleen and the diaphragm in the left upper quad, but you're also evaluating for any fluid in the thoracic cavity. Over here is the suprapubic view. You're evaluating for free fluid in the pelvis. Just make sure that when you're doing these views, you see it in 2 orientations and fan through the entire structure so you don't miss a small pocket of free fluid, as you can see in this image over here. Subxiphoid view, you're evaluating for a pericardial effusion. You use the liver as a window. You flatten out the probe all the way until you have the beating heart, and you're looking for the pericardial effusion. When you're looking at the anterior chest, you're looking for lung sliding. One thing to help you with the exam is to take out a lot of depth, because previously with the other parts of the exam, you had increased depth with the probe. Take out the depth to really get a good view of the pleural line. You're looking for lung sliding, which looks like ants marching on a line. If you're not sure if you see it, you could always put on M mode, and you'll see the image on the right, which is the sandy shore sign. Over here, you see an image with no lung sliding, absence of lung sliding. If you're not sure, you put on the M mode and you see the barcode sign. If you happen to see this when you're doing the thoracic imaging, this is called the lung point. It's actually the area where you have the visceral pleura of the lung separating from the parietal pleura from the pneumothorax. This is just about 100% specific for a pneumothorax. And what you can see on the M mode is you see the clear delineation of the area where there's pleural sliding with the seashore sign to the barcode sign. So that was just a little bit of a brief overview. Now we'll really get into the nitty-gritty of discussing the special populations, specifically with regards to pediatrics, young women, and pregnant women with the eFAST exam. We'll start off with pediatrics, and we'll discuss a case. So you're working and you receive a trauma notification for an 8-year-old male that was in a motor vehicle collision. He was a restrained rear passenger in an Uber that was T-boned when passing an intersection. He denies LOC, but complains of abdominal pain. The primary survey is intact. Secondary survey, you note a seatbelt sign as seen in this image. The vital signs were all notable for a heart rate of 120, otherwise unremarkable. The eFAST initially is negative. What are you going to do with this information? What's your next action? Can you rely on a negative eFAST, or does this patient actually require further imaging and evaluation? So I gathered through some data to see the pediatric studies to see how sensitive and specific actually the eFAST exam is with regards to abdominal trauma in pediatrics. Looking at the names, you might recognize some of the names. This article was published in Pediatric Emergency Care in February of 2021. It evaluated the utility of the eFAST for the diagnosis of intra-abdominal injury in children presenting with blunt abdominal trauma. It actually is a systematic review evaluating 8 studies encompassing just over 2,000 patients with a weighted prevalence of intra-abdominal injury at 13.5%. It included studies for the pediatric FAST exam that was done in the ED for blunt abdominal trauma. It excluded studies for patients who died in the ED, were hemodynamically unstable, or met criteria for emergent surgical exploration. In short, this is really what they found with the sensitivity specificities of all those different studies. And when they pooled the sensitivities, they found only a 35% sensitivity, specificity of 96%, positive likelihood ratio 10.84, and a negative likelihood ratio of 0.64. The data is very significantly different than all the studies with the adult eFAST. The conclusion of the study was that a positive FAST makes intra-abdominal injury likely. A negative FAST alone cannot preclude further diagnostic workup. So the real question is, why is the data so different between adult and pediatric studies? When I was looking through it, what I found is really that the only explanation is simply that the majority of the studies with regards to the eFAST are primarily with adult studies and with fixed outcomes, very common outcomes. However, in the pediatric populations, there's a lot less data, so which gives you less numbers. You can't really get good systematic reviews. This was actually a prospective observational study that looked at children less than 18 years with blunt thoracic trauma, published in the Journal of Trauma and Acute Care Surgery in September of 2014. The purpose of the study was to evaluate the variability of clinician-performed FAST exams and its impact on the use of CT abdomen in hemodynamically stable children with blunt torso trauma. The primary outcomes were the frequency of the FAST exams, the frequency of the CT abdomen, the number of patients with missed intra-abdominal injuries. It included 12 centers, consisted of just under 6,500 pediatric patients with blunt thoracic trauma. Of note, what's significant is that of those 6,500 patients, only 887 patients underwent a FAST exam, 13.7%. And interestingly, what that study found was that as the provider's suspicion for intra-abdominal injury increases, so does the rate of the FAST exam use. And as the rate of the FAST exam increases, the rate of CT abdomen pelvis decreases. So if you have a higher suspicion for intra-abdominal injury, that means that you'll do the FAST exam in the pediatric. If it's negative, if you're borderline suspicious, you may hold off on the CT. And the reason for all these studies actually is because we want to limit the amount of radiation exposure to pediatrics, because we all know that cumulative radiation increases risk for cancer. So ACEP kind of breaks it down in a policy statement, and what they did, they reviewed all the information which I discussed plus a lot more, and they found that only 15% of pediatric trauma centers in the US currently have adopted the FAST exam as part of their trauma algorithms in children, mostly because of the rare occurrence of unstable children with intra-abdominal injuries. They found that many of the pediatric studies apply different definitions and gold standards and outcomes than the adult studies, which makes it difficult to compile large systematic reviews to get accurate information. So ultimately what they recommend is that we really need further studies of the FAST exam in pediatrics. And currently, the FAST exam should be utilized to prioritize CTs in areas where CT use is limited. They also say that if you use the FAST, you can increase its utility with serial FAST exams. So when I was looking to find information on the use of serial FAST exams and whether we can actually use that reliably to reduce the amount of CT abdomens that we're getting in kids with abdominal injuries, the data is very, very limited. These were the two most common papers that I found cited. They were two prospective studies that demonstrate increased sensitivity with the serial FAST exam, but I'm really not going to go into the details about it because it was so minute with the increase in sensitivities, and they were very small sample sizes, and honestly, like the data was really, really weak. So it really wasn't worth discussing in depth these papers. However, it is a good thing to think about when you're faced with the pediatric patient that you don't want to expose to the radiation. Your suspicion is low to moderate for having an intra-abdominal injury. You do the first FAST and it's negative. You really should consider serial FAST exams to guide your resuscitation. So some tips and tricks for the pediatric patient with regards to performing the exam. In smaller children with narrow rib spaces, instead of the curvilinear probe, you may actually use the linear probe, just the vascular probe. You don't need as much depth and you get actually a good window in between those rib spaces. It helps to warm the gel. This way it's more comfortable for the patient and they're not fidgeting around when you're trying to get the exam. If you Trendelenburg the patient for about 5 minutes in the bed prior to performing the exam, fluid will go to the dependent areas, giving you a higher likelihood of finding that fluid in the abdomen. And you should consider serial FAST exams for hemodynamically stable patients with a lower suspicion for the intra-abdominal injury. Let's move on and talk about pregnancy and young women that present with abdominal trauma. First of all, in pregnant females, there are numerous anatomical changes that will affect your FAST exam. So the uterus in early pregnancy is actually still remains in the pelvis. However, as the fetus grows, the uterus expands into the intra-abdominal cavity. Although the maternal abdominal viscera are thought to remain in locations similar to the non-pregnant state, what they actually found is there's a lot of observational data that suggests an increase of 25% chance of hepatic and splenic maternal injuries after blunt abdominal trauma. Also, due to the size of the uterus and the fetus in there, your pelvic view may be obstructed when you're trying to get a FAST. You may not be reliably able to evaluate for pelvic free fluid. Like we did with pediatrics, let's discuss a case. So you're working in CCT and you receive a trauma notification for a 27-year-old female bicyclist struck with LOC. Now she's back to baseline, currently alert and oriented. Primary survey is intact, secondary survey just noted with abrasions on her bilateral arms. Her vitals are stable. You perform an eFAST. In the suprapubic view, you see the image above. What do you do next? How do you interpret this image? You know, we always hear about physiologic free fluid in young women. So we know that it's common to find physiologic free fluid in women of childbearing age. There's varying amounts of free fluid depending on where in their menstrual cycle it is. The studies show that the greatest volume is detected during ovulation, and the prevalence of transient physiologic free fluid in young women is actually 36 to 40%. So with a patient who is a multi-trauma patient, and you see this image, are you going to interpret this as physiologic free fluid, or is this a positive FAST? What are you going to do next? Similar to children, young women and pregnant women, you want to reduce the amount of CT abdomen pelvis that you're obtaining to reduce the amount of radiation, if at all possible. That's the whole reason to discuss this topic. So this is a prospective observational study that was published in the Journal of Radiology in 2001. It looked at just over 1,000 women aged 10 to 60 years old, but the mean age was 33. They were screened with ultrasound for blunt abdominal trauma and admitted to the trauma surgery service at a level 1 trauma center between April 1994 and December 1998. Patients were assigned to 5 groups on the basis of and the presence of location of the intra-abdominal fluid, whether there was no intraperitoneal fluid, whether the fluid was only in the cul-de-sac, whether the fluid was immediately superior to the bladder in the pelvic view, or whether the fluid was outside of the pelvic view, also throughout the whole abdomen. What they found, they compared the clinical outcome, they compared the ultrasound results to the clinical outcome and the use of CT, repeat ultrasounds, the cystographic evidence, DPL, surgical and/or autopsy findings. And the screening ultrasound had an 89% sensitivity and 97% specificity with an accuracy of 61%, positive predictive value of 99%. So what they really found was that if there is free fluid in the pelvis, you can't just call this physiologic free fluid. So their recommendation in the conclusion of their study was that if the fluid is isolated to the cul-de-sac and your clinical suspicion for intra-abdominal injury is low, then you can follow them just by looking at serial exams without performing the CT. However, if you have a higher clinical suspicion or the fluid is anywhere outside of the cul-de-sac, you're going to need to require further imaging. So that one discussed women of childbearing age. This is a paper also that was published in the Journal of Radiology in 2004 that was more focused on looking at pregnant women. It's a retrospective review. It was a retrospective review of all consecutive emergency blunt trauma ultrasound exams performed at a level 1 trauma center between January 1995 and June 2002. This is actually the largest study to date. It included just under 2,500 ultrasound exams for blunt abdominal trauma. The caveat to this study is actually that of those 2,500 women, there were only a little over 300 women that were pregnant. So still very, very small population of pregnancy. And the mean, sorry about that. The mean age of the pregnant group was 24.7. The mean age of the total group was 27. They compared the surgical reports with the ultrasound as well as CT reports. And what they found in the pregnant patients, the sensitivity of ultrasound decreased to 61%, and the specificity was still 94%. The conclusion of that study was that for the detection of intra-abdominal injury, ultrasound was significantly less sensitive for pregnant patients, but the specificity was still about the same. However, the sensitivity was highest during the first trimester. I would assume that it's in the first trimester due to mostly because you can actually get a better view of the pelvic region, the pelvic images in early trimester as opposed to when the fetus and uterus is large. So this was an article that was published in the Journal of OBGYN in 2019 based on the data of the previous study. It discusses in depth all the challenges regarding the pregnant trauma patient, the anatomical physiologic changes that occur during pregnancy, the approach to evaluation, and the multidisciplinary team approach that is needed when it comes to the pregnant trauma patient. Shameless plug for the Code 54. What it found is, ultimately what they say is that the fast sensitivity was 61%, specificity was 94%, accuracy 92%, which suggests that the fast may be less sensitive in pregnant patients for abdominal injury, but it still remains highly specific. An equivocal fast exam requires alternative imaging techniques to identify traumatic injuries, and if imaging is clinically necessary to assess for maternal injury, the indications for imaging should be the same as for a non-pregnant trauma patient and should not be eliminated or delayed. This is actually a policy statement from ACOG regarding pregnant trauma patients. And what it says is that the radiographic studies indicated for maternal injuries, including CT abdomen, even though they will get exposed to the radiation, if you have a high suspicion, pretty much do the test. If you have a high clinical suspicion for intra-abdominal injury, don't be afraid to scan them. They should be evaluated the same way as the non-pregnant patients. ACEP weighs in as well with similar recommendations, saying that the FAST scan is fast and safe. You should initially screen patients, trauma, no matter what the demographic, first with the FAST exam. However, if your clinical suspicion is high, then you should be performing a CT scan regardless of the radiation. Key points that I would like you to take away from this talk is that a positive FAST is highly specific for intra-abdominal injury, regardless of the demographic, whether you're talking about adults, children, pregnant, young women. Positive FAST, be concerned. A negative FAST alone does not rule out intra-abdominal injury. If you have a high suspicion, you must obtain further imaging. There's many anatomic and physiologic changes that occur during pregnancy. If the mechanism and the abdominal exam are concerning, scan. Go through the same route that you would for the non-pregnant patient. And although there is commonly physiologic free fluid in the pelvis of young women, if the mechanism and exam is concerning, you should still obtain further imaging. Don't stop there. You can definitely perform serial FAST exams for patients with a lower suspicion, and that may be able to reduce the amount of CT scans that you are getting, but if your suspicion is high, scan. And these are my references. Any questions?
That was a great talk. I think it's really important to understand how to utilize a FAST exam. And you see it all the time, like every single patient that comes in with trauma, they need a FAST exam. Like they're on their way to the CAT scan and they're getting a FAST exam before they go to CAT scan. That's a complete waste of time. I'm not saying you shouldn't do it, right? Because you need to know how to do FAST exam. So you should do as many FAST exams as you can in order to know how to do the FAST exam when it's actually going to make a difference. But it's really only useful in the unstable patient. If you have, and that's one trauma, there's penetrating trauma. If you have an unstable penetrating trauma, the FAST exam isn't really going to change anything. And if you have a single patient with penetrating trauma, the FAST exam is unlikely to really change management, right? Because patients really get CAT scans, right? Because the FAST exam is really a surrogate. It's not telling you anything about the injury or what's happening to the patient, right? If you're a surgeon, you're going to open somebody up, you want to know what you're opening up. Saying that there's free fluid doesn't really tell them anything. It's a surrogate. So for the unstable patient, you're like, well, we don't have time to figure it out. This patient's got to go to the OR if their FAST is positive. But if their FAST is negative, then you got to say, okay, where is the site of their injury that's making them unstable? But in a stable patient, if you have any concern for injury, you're going to get a CAT scan because that's going to give you much better information. Is the CAT scan going to tell you everything? No, it's not going to tell you about diaphragmatic injuries and subtle bowel injuries. You're going to miss that stuff on CAT scan too. But you really have to realize that you should not be making decisions on FAST exams in stable patients. Period.
Thank you.